Thank you, George. Terrific. I think this is controversial, so I thought I would start with this. It says all you need in life is ignorance and confidence, and success is sure. I don't think so in this case. I don't think my job is easy here. And there are no large data in all comers yet, but hopefully soon this is to come. So what are the key arguments? TAVR can be done very safely with low procedural mortality and strokelets, in fact, lower than surgery. TAVR has better hemodynamics compared to surgical aortic valve replacement. Patient prosthesis mismatch is more common with surgical aortic valve replacement and associated with worse clinical outcomes. There are no real definite differences between TAVR and SAVR in durability. If you look at it very objectively, TAVR may be more suitable platform compared to SAVR for future reintervention, and I think that's an important consideration. So these are the important studies, right, related to the SAPIEN 3 valve and the SAPIEN valve. And if you look at 2,000 patient randomized clinical trial, if you look at the combined endpoint in intermediate risk patients, all-cause mortality and disabling stroke was statistically lower. I promise you, if it was the other way around, TAVI would be dead. Looking at the SAPIEN 3 data now, which is in a non-randomized but in a propensity-matched fashion, and if you look at the incidence of death and stroke, it is 2% versus 8% with surgery. And at 1 year, the incidence is half. So how can you not make an argument for TAVR? Not only that, but the acute kidney injury, the major vascular complications, all of these are actually much lower, and there's not a lot of difference here in this particular study between the pacemaker implantation rates. Intermediate risk, the TAVI data, once again, very similar, all-cause mortality and disabling stroke between core valve as well as surgery. This is a very important study. It's a small study, almost 300 patients. If you look at the 6-year data we presented recently, STS less than 3, mean age 78, the outcomes are not different all the way up to 6 years. If you look at some of the real-life situations now, using the minimalist approach, look at the 3M TAVR registry. All right, you're talking about 30-day mortality of 1.5%, 30-day stroke rates of 1.5%. These are extremely favorable. I think this is a very interesting study, and it's going to be published and presented fully in the coming months. This is Ron Waxman's study. 125 patients were enrolled. This was presented by him. The mean STS score is 1.9. Mean age is 74, and 80% of these patients were done using conscious sedation. But this is the result. 0 mortality at 30 days, 0 stroke rates, 4% pacemaker implantation rate. That is pretty good. Valve hemodynamics, I think this is the biggest kept secret, in my opinion, about the surgical valves, that their hemodynamics are actually inferior. So if you look at the patient prosthesis mismatch, almost 2/3 of the patients, large study, 60,000 patients from the STS database, and if you look at almost 2/3 of the patients have patient prosthesis mismatch. Look at the distribution of the valves. 45% of the patients undergoing surgery have valve sizes 21 or less, and 75% of the patients have 23 or less. I think that's not good, because if you look at the outcomes, they depend upon the patient prosthesis mismatch. Look at the mortality is actually worse in patients with patient prosthesis mismatch. If you look at TAVR, it is better compared to surgical aortic valve replacement when it comes to patient prosthesis mismatch. My third argument is there are no data actually to suggest that TAVR durability is less than surgical aortic valve replacement. Look at the hemodynamics here. If you look at the p-values, they're all in favor, at least at 5 years and 3 years, in a number of different studies, in favor of TAVR devices. Look at the difference in valve areas there in the NOTION trial, 1.66 versus 1.23. That is pretty impressive. The whole thing about durability in surgical valves is, I think, needs to be understood. There is a lot of variation in the definition of structural valve degeneration of surgical valves, and I think that is important. The surgeons will often define a valve as a durable valve as freedom from reoperation. Right? So a patient could be dead, not come back for reoperation, but in the publication, that's actually considered to be a durable valve. I think that's not right, and that's not fair, right? So I think that's important. If you look at the VIVID data registry, this is Danny DeVere's data, the median time for valve-in-valve was 9 years. But look at the distribution. Almost 20% of the valves, surgical valves, failed within the first 5 years. I can tell you that that doesn't seem to be the case with the TAVI valves. So I think we are not on a definite ground, but I think things seem to be safe. So now what has been done is there are uniform definitions for durability for both surgical and TAVR devices, and I think we'll learn more. In fact, if you apply the definitions of structural valve deterioration, which depends upon elevations in gradients by 10 millimeters of mercury, you see that actually TAVR valves are better than surgical valves. Bicuspid is a big issue because almost 50% of the young patients have bicuspid aortic valves. But it's important to remember that all bicuspid valves are not equal. You know, the valve in the upper corner would just do fine with TAVR, while the lowest in the right corner would actually be a bad case for TAVR. So what is the data with? So here is a multi-center registry with newer generation devices. The outcomes were actually pretty good. They were not different compared to tricuspid aortic stenosis, including one-year mortality. We recently presented data from almost 1,800 bicuspid aortic stenosis, comparing them to tricuspid aortic stenosis. And if you look at it, the incidence of bad things happening, such as annulus rupture or going on cardiopulmonary bypass, is about 1%, coronary obstruction 0.4%. So not, yes, it is harder than tricuspid, but it is still quite acceptable. If you look at the outcomes at 1 year, in fact, they're actually similar. So this is similar mortality in the TVT database. But one must be prudent. So here is the valve that we did as a live case a few years ago. This patient's ejection fraction was 15%. Nobody wanted this patient, so we did this TAVI. All right, and I show this to you because it was not easy. It needed 2 valves. All right, the patient got out of the hospital. The EF actually got better, but 2 years later, there was actually a lot of AI, and that's because there was actually a pseudoaneurysm of the aortic root. So this patient actually had to have surgery. It did the job, but nonetheless, it's a cautionary tale. The next argument is that surgical bioprostheses are not a good platform for future TAVR. All right, and in fact, the preliminary experience suggests that TAVR in TAVR is feasible with good hemodynamics. So here is the data on the valve in valve, which is TAVR in failed surgical valves, which is pretty good. 2.7% 30-day mortality, 1-year mortality of 12.4%, good hemodynamics at 1 year with very little PV leaks. But this is an important piece of information. It says that when you do valve in valve, or when you do TAVR in failed surgical valve for small valves, okay, that is when you have really bad outcomes. So the right thing to do is not to put a small valve, surgical valve to start with. Here is data of TAVR in TAVR. Okay, so at least the hemodynamics seem to be quite favorable. And here is just one such example of a valve that failed at 6 years. You can get excellent hemodynamics in these patients. This is a multi-center registry, once again, looking at in-hospital outcomes, and they're actually quite favorable for failed TAVR. Using a TAVR in TAVR, 1-year outcomes also seem to be quite acceptable. So I'm going to actually float an idea which was introduced, in fact, by Michael Mack. So his suggestion is, in fact, you could take a young patient, start with TAVR, so you can put a bigger valve, and then you can do a TAVR in TAVR, and then do a surgical aortic valve replacement, or you could go the other way around. I mean, so you could actually, rather than actually do the surgical aortic valve replacement first. So I think, so that is the key concept to sort of remember, and I think the other important thing is that TAVI may be expensive for the hospitals, but for the healthcare system, it actually makes sense. There are actually lower 2-year costs with TAVR compared to surgical aortic valve replacement, and also that is the case with the SAPIEN 3 valve. So very quickly, in 30 seconds, this is a 71-year-old patient who got a small valve, 21 millimeter mitral flow. 3 years later, she fails this valve. Okay, we do a TAVI. There was a lot of drama here. Left main occlusion, we bail the patient out, patient does okay. You can look at the gradients, they are quite significant. At 4 months, the gradients are up to 60 millimeters of mercury. We send her back for surgery. Guess what she gets? Another small valve. 19 millimeter surgical valve with the true ID of 17 millimeter. I think this patient would have done better with the TAVI device in the first place. So it's not a surprise. TAVI volumes are increasing. I've presented my arguments. So I think we must make the argument that anatomy not the age should determine whether a patient is actually a candidate for TAVR or SAVR. And I think some of these ongoing studies and upcoming studies will actually help us take care of this answer. So I would say to the skeptics, be open-minded. You know, the little guy sitting there is telling the old guy, you know, I didn't really believe in reincarnation when I was your age either. I think we must be open to the idea of